First one we in acyanotic heart diseases, the first one we'll be reading is transposition of great arteries. Now, why we reading this is that this will be the patient with cyanosis at birth itself. See, the most common is TOF. I agree. But a baby is born and you see cyanosis, it's more probably a TGA. Now, what is TGA? It's nothing but, see, aorta should arise from the left ventricle. Here it's rising from the right ventricle, and from left ventricle you see pulmonary veins. So this is what has happened. There's a switch in the arising of the aorta and pulmonary veins. Now, what happens is that because of the switch, the aorta now will be right to that of the pulmonary artery. It's usually to the left. Exactly, it's usually to the left. Now it's become more right towards. If you see here, it's in the right. It's supposed to be like this, right? Okay. Now, if you have with VSD and without VSD, if you have with VSD, what happens is that it's a kind of a compensation. So you'll have cyanosis, but the CCF will be present at 4 to 6 weeks of age. But if you do not have VSD, immediately you'll have cyanosis with no murmur. Now, if you see the heart sounds, you'll have no murmur and you'll have a single P2 S2 sound, not much of difference. And in X-ray, you'll see an egg on the side appearance. Egg on the side appearance. Now, a thymic shadow will be absent. Now, the 3 steps for treatment. Its first step is PGE1 analogs. Now, PGE1 analogs we also give to coarctation of aorta, so that will be the first choice for up to 2 weeks. Step 2, you have to create an ASD. If you create an ASD, what happens? It's like you're reversing the switch with help of balloon atrial septoplasty. See, this is the balloon atrial septoplasty. You're creating an ASD, and next is last step is less than third, that is known as Rashkin balloon atrial septoplasty. If it's less than 12 weeks, if the child is less than 12 weeks, you do Jetain's procedure. It's an arterial switch. You switch the aorta and pulmonary artery. More than 12 weeks, you switch the atrium itself. That's called a Mastod and Senning procedure. Apart from that, if you correct the TGA, what happens is that earlier on stages you'll have conduction disturbances. If you do this Mastod and Senning, you'll have conduction disturbances. So that will be present. So this is the most important part of TGA. And TGA again, there's no murmur, cyanosis immediately at birth or third day, whatever it is. Within a week, you can have cyanosis, CHF, egg on side, and all. It is also seen with PKU mother. It is what's PKU? I forgot. Okay, fine. So next we will do total anomalous pulmonary venous connection. It's another acyanotic heart disease, and you will have just a sec. In total anomalous pulmonary venous connection, you will also have increased blood flow and recurrent pneumonia. It's same as that of TGA, the same thing, same presentation. Now in Tapvc, what happens is that normally all the pulmonary veins will drain into the right ventricle, right? I mean, it eventually comes back to the right ventricle. What happens is that it will drain into the SVC, you say it as supracardiac. If it drains into the right atrium, it's cardiac, and then the IVC, you say as infracardiac. Now this is the only congenital anomaly where all chambers of heart have equal saturation. 85% O2 will be present in all chambers of the heart. With the supracardiac, what happens is that is if it drains into the SVC, you'll have CCF, you'll have ASD, you'll have cyanosis. And it's a cardiac, also it will be the same, and it's a non-obstructive type. Infracardiac is what happens. You'll have ground glass cyanosis, but you'll not have cardiomegaly. So supracardiac is the most common type, and you'll have day 1 cyanosis on day 1. Regarding heart sounds, since they have a VASD component, you'll have a fixed S2 split. cyanosis will be present, CCF will be present, and you'll have a figure of 8 appearance, snowman appearance, the supracardiac type. And also there's something known as a scimitar triad. Scimitar triad is when the pulmonary veins of the right lung drain into the IVC. It causes an obstructive lesion. See, this is known as the scimitar sign. This is known as the scimitar sign. So right hypoplastic lung, dextrocardia, and mediastinal shift, and all these things will be present. This is known as scimitar triad. Right hypoplastic tongue, dextrocardia, scimitar sign will be present. And infracardiac, again, that's what I told you, and it is an absolute surgical emergency, is an infracardiac. This is a scimitar triad, which is an infracardiac, will be an absolute emergency condition. All right.